Good evening, friends. Welcome to the PG Clinic broadcast. We are doing a broadcast out of turn because of the torrential rains in Chennai. The city is paralyzed, so we had to postpone yesterday's broadcast from there. Our thoughts are with all our friends there, and I hope they are safe and they're well. We will be doing the broadcast from Mumbai today, and the Chennai broadcast will happen next week on the 9th of December at 2:30 p.m. Of course, you will get a message regarding this as we've been informing you about the other clinics also. So, without further ado, let's begin. And of course, I must acknowledge the um, generous grant given to us by Wockhardt Vaccines to conduct this activity, which is uh, for the benefit of postgraduates and the future of pediatrics. Today's case is being presented by Dr. Nikila. Please come.
Good evening, everyone. My patient, a 5-month-old male infant by name Jai Sagar, second born to a distant consanguineous marriage, hailing from Ahmednagar, Hindu by religion, Hindu Sari by community. The patient was apparently alright 1 month back, that is till the age of 4 months, when the parents noted breathlessness in the baby in the form of increased rate and depth of respiration. There were no other complaints at this time. The baby was then taken to the local doctor where blood investigations were done, and the parents were told that the baby had very low hemoglobin, and the baby was transfused 3 units of red blood and 1 unit of white blood, most probably platelet concentrate. Doctors also noticed abdominal fullness in the infant, which was not noticed by the mother till then. So the mother now gives a history of abdominal fullness, which were more in the upper abdomen and more in the left upper quadrant compared to the right side. The baby was admitted for 12 days and was on IV medications and discharged. And 1 week following discharge, the mother noticed an increase in the abdominal distension and went back to the doctor, wherein the blood investigations were again done and 1 more unit of red blood was transfused, following which a bone marrow aspiration was performed. Following this, the baby was referred to Sion Hospital for further workup. There's no complaints of cough, there's no complaint of fever or suck cycle, no complaints of icterus or altered urine or stool color in the baby. There's no history of blood transfusion in any of the family members or the siblings. There is no history of previous sibling deaths or any abortions in the mother. There is no history of any unusual body odor or urine odor or altered stool color. There's no history of repeated infections in the past or any particular ecchymotic rash in the baby or any source of blood loss in the baby. There's no antenatal history of fever with rash in the mother or any drug intake in the mother in the antenatal period. There's no history of convulsion, lethargy, feed refusal or failure to thrive in the baby as per the mother's history. There's no history of Cox contact. The past history: prior to the age of 4 months, there were no significant medical or surgical illnesses in the baby. Coming to the birth history, antenatal, the mother was registered and immunized in the first trimester. She took iron and folic acid tablets for 3 months, and she said she took 100 tablets. There's no history of fever with rash during that period, and no history of drug intake or radiation exposure. Sonography was conducted, 3 sonographies, and all of them were normal. There was no finding suggestive of any fetal anomaly. The mother experienced quickening at 5 months. Natal history: the baby was born of a full-term normal vaginal delivery, cried immediately after birth, and there was no resuscitation required. There is no history of requirement of any NICU stay in the postnatal period, and there is no history of neonatal jaundice in the baby. The postnatal period: the mother and the baby were discharged on day of life 3, and ever since then the baby has been feeding well and there have been no complaints. Immunization is up to date. The baby has received the birth vaccines and the vaccines at 6, 10 and 14 weeks. Next due for 9 months vaccine. Feeding history: The baby has been exclusively breastfed since birth and it's been fed at demand. Developmental history: gross motor, neck holding was achieved at 3 months and currently the baby can roll over. Fine motor, palmar grasp is achieved. Language, the baby is able to coo and make sounds. Social, the baby has attained the social smile at the age of 2 months. Currently it can recognize the face of the mother and the face of the father. It turns to the direction of light and sound. Family history: the baby is born of a distant consanguineous marriage. 29-year-old father who studied till the 10th standard, vegetable seller by occupation, earns about 6,000 per month. 24-year-old mother, 7th standard, and she who is a homemaker. They live in a 2-roomed house as a family of 6 with 3 earning members, and they belong to the upper lower class of according to the modified Kuppasamy classification. That's my history.
Okay, so let's start with the chief complaint. Chief complaint was breathlessness noticed in a 4-month-old child, right?
Yes.
5 months and at 4 months
4 months
breathlessness. So how would you approach this? The subsequent history is kind of sort of giveaway, but if you were to be facing a 4-month-old child who's brought for breathlessness, what questions would you ask, which I think we didn't get in the history? So how would you approach this child? Ask for the mic and speak in the mic.
Any associated fever and the activity of the child during that period.
Yeah, so why are you asking that? Association with fever?
Ruled out any respiratory tract infection.
Okay, so respiratory tract infection. So obviously you will ask for associated complaints and fever is right, but even before that, would you like to ask about the breathlessness
cough,
itself?
And any diurnal variation of the breathlessness or the
Okay.
activity of the child, otherwise whether feeding was proper or not during the breathlessness, whether the child was sick or he was active or not during that period.
Okay. So what will all these things tell you? Diurnal variation will happen in what? Sick or not sick will tell you what? Feeding or not feeding will tell you what?
Any chronic pathology like
Okay, so sick will tell you that it's either
Bacterial.
acute pathology or a chronic severe. Okay, but so in general, when you have any complaint, what is it that you have to ask about that complaint? What kind of details do you ask? Any complaint,
onset, duration and progress.
onset, duration, progress. So in this, of course, like I said, subsequent all blood transfusion and all, but if a 4-month-old comes, tell me how will onset, duration and progress make a difference to your thinking? 4-month-old with breathlessness, what are the possibilities? Forget this history of blood transfusion and all, then it becomes narrow.
Bronchiolitis.
So first you would think of a common situation like bronchiolitis. So the onset would be
Sudden onset.
quite quick. In fact, half the cases of bronchiolitis, parent may not complain of breathlessness, and what will they come with?
Mostly cough and breathlessness.
Or feeding difficulty or excessive crying.
I think to begin with, you must tell me, is the breathlessness coming from which system? Is it respiratory, it is cardiac, basically? Or is it a metabolic acidosis that we are missing, just as tachypnea in a breathless child? So be sure that is breathlessness a tachypnea alone or really a respiratory distress? So the first question should be, is the baby in distress or is the baby just tachypnic? Now the tachypnic could also be before the distress comes in. but a metabolic acidosis is not in distress. So if the mother says only tachypnea, so what questions would you ask to be sure that there is distress or no distress? That's one. If there is a distress, metabolic acidosis is out. Is it respiratory or cardiac? Now cardiac could be cardiac causes or extracardiac causes. Respiratory could be also similar. So first give a thought, where is this breathlessness coming from? For example, respiratory could be a CNS cause of a respiratory increased rate or even an abnormal rhythm. So was it a CNS cause of a respiratory problem? If cardiac could be a hematological problem causing a cardiac problem, but first respiratory, cardiac or metabolic.
Ask about the history of any irritability and look for any nasal flaring during examination and any history of suck cycle and perspiration over forehead during feeding, any difficulty in feeding.
So to sir's question, that how will you find out on history whether there's distress or no distress? How will you find out? Based on ability to feed and all this, right? So a distressed child will have difficulty in feeding, whereas if there's no distress, there will be no difficulty in feeding. Okay? So this onset, duration and progress will help you to decide, as sir said, where this breathlessness is coming from. Okay? So we said bronchiolitis or respiratory acute onset. Then in this case, did you ask about the onset? Meaning, the point is, was it one fine day that the mother noticed breathlessness, or has it been built up over a period? Today she noticed breathlessness, today she went to the doctor, or?
She noticed over a period of 2-3 days, following which when it increased on the third or fourth day, she went to the doctor.
Okay.
But there was no involvement with feeding. She said the baby was feeding as well as it was feeding before.
Okay. And so now answer sir's question. How will you decide whether a given breathlessness in a 4-month-old is respiratory or cardiac? Or metabolic? That's the third one. Come on, what questions would you want to ask?
So in cardiac, there will be feeding difficulty, suck cycle, whereas in bronchiolitis, the feeding difficulty may not be so much like in cardiac.
So we have discussed this in earlier clinics also. So what is the difference in with respect to this ability to feed? What is the difference in a cardiac cause of breathlessness and a respiratory cause of breathlessness? Is it that respiratory can feed better and cardiac can't feed? Is that the thing, or there is some other difference? Come on, we have discussed.
Cardiac, the metabolic need is higher, so the baby will easily get tired very soon.
Yeah, but respiratory also the need is higher, no? Bronchiolitis, the respiratory rate is 80 per minute, and plus the baby is hypoxic because the baby is not not acquiring enough oxygen. So there also there is a discrepancy between the acquiring of oxygen and the demand of the body. What do you think? Come on, anybody, we've discussed this. What is the difference in feeding of a bronchiolitis baby and a cardiac heart disease baby? We said suck, rest. So what does rest do to the breathlessness or to the feeding?
Improve the...
Which will not happen in a respiratory cause of breathlessness. So in a cardiac cause of breathlessness, in both there is difficulty in feeding. But in a cardiac cause, after taking rest, there is some amount of energy restored. So the baby can again take feed and then again gets tired and becomes unable to feed. Whereas in a respiratory, after a point where tachypnea is reached, the baby's difficulty to feed is continuous till that tachypnea settles down. So rest doesn't do anything.
Onset would be important. How did it start? The mother must now, tachypnea is a complaint which the mother has come with. So how over a period of 3 days it has started, and how has this baby been feeding all these days and alertness has been there, and is there any vomiting? If this baby's alertness has been maintained and over a period of 3 days the baby is gradually becoming more and more tachypnic, then CNS cause giving rise to this is less likely, because if the baby has become so much tachypnic, some CNS problem by now, either drowsiness, irritability, decreased activity, something would have come. Secondly, in the metabolic disease, usually vomiting along with breathlessness is often a feature, plus altered level. So if the baby has been maintaining reasonable level of alertness, and the baby has been feeding also reasonably well, that means this breathlessness has not done much to the vital activity or the daily activity of this particular child. So this breathlessness has been slow and not very severe, because the baby is continuing to feed. Now, as he said, breathlessness child in bronchiolitis would be, there will be refusal to feed. It will also depend upon how slowly is the onset. Bronchiolitis is an acute illness, so they will come for refusal to feed rather than tachypnea. But if there is in a 4-month-old child, you always keep at the back of mind congenital malformations developing very slowly and may come over a period of time as tachypnea, but they are slow in onset. So I think neurological causes and metabolic causes are less likely. That's conclusion number 1. Conclusion number 2 is this particular breathlessness not very acute and not done significantly anything to the physiology of this particular baby. This baby is feeding well. If it is and it is not an acute onset, most of the illnesses of respiratory onset will have respiratory symptoms, and most of them in this age is acute unless it's slowly coming up congenital pathology like maybe diaphragmatic hernia or some such thing. Then other usual problem comes with cardiac and respiratory. So cardiac is more likely, even if there is associated cough. We saw that children with cardiac problems, left to right shunt, etc., have cough and recurrent cough and breathlessness and cough and breath. So between the two, perhaps cardiac more likely. So when I say cardiac giving rise to breathlessness, we saw that it is a congestive cardiac failure. So till then we can zero in and we can say that this particular more likely to be cardiac. And when we say cardiac, we have not completely ruled out respiratory cause as well. Then after having come to cardiac, then our problem, the next thought process which we may perhaps forget is cardiac means cardiac failure means need not be a cardiac problem, but could be as a result of anemia. Because we may often forget the anemia part of it and settle down at cardiac and respiratory, but could be anemia. So that is how I thought we would approach this.
Actually, I think if you look at the suck, every breathlessness is respiratory only. When you say it's a cardiac, it's a cardiorespiratory. And therefore, if it's a slowly progressive breathlessness, that means there is a slowly progressive respiratory problem. Now, what is a slowly progressive respiratory problem? A cardiac problem. And therefore, we say that acute breathlessness of any kind. For example, if you have an acute myocarditis, the child will be acutely breathless. And he has a heart disease, but he does not have a suck. So suck means slowly worsening pulmonary disease. But what is slowly worsening pulmonary disease? Most common, caused by the heart disease. Therefore, we say heart disease has a suck cycle. But look at an acute myocarditis, he will be like a bronchiolitis. He will not have a suck cycle. So don't make a mistake that suck means cardiac. Suck may be slowly progressive. Can a lung lesion be slowly progressive? Not commonly. Most of the congenital malformations are localized. They may often not even cause breathlessness. And if they have to cause breathlessness, they have to be severe, like say diaphragmatic hernia, when the whole lung is not working. But diaphragmatic hernia can come even at 8 years of age without breathlessness. So respiratory are rarely slowly progressive. If they are slowly progressive, they are so slowly progressive, like a chronic interstitial lung disease. Oh, that takes months or years. And by then the child is getting little older. Therefore, he doesn't say suck, rest, suck. He says, I am getting tired while walking. What is suck, rest, suck cycle? Tired while feeding. Therefore, he rests. How does a chronic interstitial lung disease come? Tired while walking or going upstairs. That is what it is. Typical mitral stenosis has that. When a mitral stenosis starts getting a left auricular enlargement and a pulmonary congestion, the first symptom is, I could walk one stair up, now I can't walk. That is equivalent to suck, rest, suck in an infant. So if you take suck, rest, suck as a exercise-induced breathlessness, and the rest relieves it for a while, in an older child, it is exercise-induced walking, etc. In a small infant, it's feeding. So when this child does not have a suck, rest, suck cycle, it only means that it could be an acute but cardiac. Can anemia be acute and cause cardiac disease? We are now discussing that. Can anemia, acute anemia can cause a cardiac disease? Anyone?
Cause acute cardiac failure.
So does an acute anemia, suppose I have a hemorrhage, large hematomasis, how do I present?
In shock. In shock.
Yeah,
Yeah.
they present in shock, not in cardiac failure.
Yeah.
So acute anemia never presents with cardiac failure, it presents in shock.
So now lastly, as sir said, this we thought we can bring it down to cardiac. In cardiac, any clues whether it is primary heart disease like a shunt as we typically see versus a extra cardiac cause of cardiac like a anemia, what is in this child? So any clues on history or anything to point to that?
Cyanosis. History of cyanosis, increased precordial activity noticed by the mother.
Okay, cyanosis no, because cyanosis we've seen so many times that cyanotic heart disease can have cardiac failure, but the commoner group of cyanotic heart disease is low pulmonary blood flow. So therefore they wouldn't, yeah, that's the commoner group. So but yeah, increased precordial activity, yes, that would be a important history to suggest that there is a shunt. What else? What are all your shunt cases which you see in infancy? What is their typical history?
Repeated respiratory tract
So what
infections
else
in the-
is there in the history as a component?
So in the past,
So do they come with breathlessness as the chief complaint, or they come with cough and breathlessness, or cough is also a prominent complaint?
cough,
Fever is often there. So these are small differences which will tell you whether it's a primary cardiac issue like a shunt, increased volume overload, or an extra cardiac. Okay. Now, did the mother didn't notice any pallor, right?
the mother didn't notice any pallor.
Okay. But now that you know that there's a blood transfusion given or whatever, so now think on those lines. So what could be the possible reason for anemia at this age?
Just before that, see, the cardiac disease is unlikely in this child because this child has had no symptoms obviously to be complained of by parents. Every cardiac child who has now come with cardiac failure or cardiac defects will have some symptomatology and then end up with cardiac failure. This child has no symptoms at all. Next is, this child is exclusively breastfed. Has he been growing all right? If he is growing all right, it is very unlikely that there is any congenital malformation. So the heart defects look unlikely. Let it be a shunt, let it be no shunt, let it be myocardial. For example, this could be a cardiomyopathy, no shunt. But even then, the child would have been symptomatic and also not growing well. So whether shunt or no shunt, whether myocardial or otherwise, this child has no cardiac disease. Then extra cardiac disease. Name any other extra cardiac disease other than anemia. Extra cardiac, but not anemia. Here anemia we know already. But suppose we had not seen this child and no history of transfusion, then which other disorders outside the heart cause a heart disease? Can a kidney disease cause a heart disease? What way?
Chronic with fluid retention.
Well, look, why should that cause cardiac failure?
Congestive
Nephrotic
cardiac failure.
syndromes are edematous.
But they are
They're fluid
extravascular.
retained. So how does a kidney disease affect the heart and cause
Can you
cardiac?
elaborate on that? So what is the mechanism? What does kidney disease cause, which in turn will affect the heart?
Come on now, I'm not asking, I'm asking undergraduate question.
Yeah.
Okay, you are thinking a postgraduate way. So,
Uremic pericarditis or pericardial effusion.
well, I can't say you're wrong. Uremics may have a pericarditis, but that's not. They have pericarditis more than breathlessness. And that pericarditis is so difficult to make out and not an important contributor of a uremia anyway.
What else is a
What is the most common?
complication of kidney disease?
I will give you a simple post-streptococcal glomerulonephritis who comes with cardiac failure.
Left ventricular dysfunction because of hypertension.
Hypertension. Okay. And now once you think about hypertension, can it be non-renal hypertension causing a cardiac disease? So go to that extent. Now name non-renal causes of hypertension. Now all that you know is you have a cardiac failure. And you know extra cardiac disease causing cardiac failure. One is anemia. We will discuss anemia in this child. Different types of anemia. But there could be different types of hypertension. Kidney disease. You would have asked for oliguria, edema, etc. So no kidney disease. Which other non-renal disorders cause hypertension which may come and fool us as cardiac failure? Not difficult. Come on, think.
Pheochromocytoma.
So endocrine causes. Okay. So endocrine causes.
What endocrine? Be little more specific.
She said pheochromocytoma.
Okay, pheochromocytoma. All right. Any other endocrine cause? Pheochromocytoma is not so common. I know, you're right. And you may have an episodic hypertension, but something much more.
Which are other causes of hypertension, endocrine, which we do come across once in a while? Cushing's at this age, 4 months, okay, but anything else? What about adrenal hyperplasia, CAH varieties? Okay, so means as sir said, start thinking that non-cardiac.
How are you sure that this is not a simple coact? Now we will see peripheral pulses are not felt. Lower limb pulses are not felt. It's a coarctation. So think beyond all that. Okay. And therefore there are many causes of hypertension. Okay. And lastly, does an increased intracranial tension cause hypertension? Yes? So how will you roll that out? Cushing's triad, people talk of bradycardia, hypertension, etc.
This child is active and alert as per the
First thing, it's extremely rare. It's only in an intensive care in a late stage. So don't bring in on discussion in our cases. But just to make a point that occasionally a raised ICT may also have a little raised blood pressure, and you may wrongly consider it as a systemic hypertension, but that is never so high to cause a cardiac disease. And therefore, just to bring a point, yes, even those diseases may fool us with hypertension.
So just one small point that acute presentation can be of a chronic disease also. because the chronic disease can progress to a certain level which is not noticeable, and then suddenly may have appeared to worsen. Like for example, this particular child is worsened for 2 days, may have even worsened for 1 or 2 days. Anemia has been there progressive for so many days, has not been symptomatic, the symptoms were overlooked because they are not. Similarly, hypertension. So if somebody presents as relatively acute manifestation, it doesn't rule out a chronic pathology.
Okay, so now anemia. So now considering that this child has presented with failure and which is due to probably anemia, now what are your thoughts? So thought processes on a 4-month-old infant coming to us as failure due to anemia. How will you think? Then we'll narrow it down. You want to talk? Tell us.
It could be a physiological anemia of infancy.
Okay, so does physiological anemia present as failure?
Unlikely. It usually doesn't present as failure. It presents as a drop in the hemoglobin. But
So does
patient is not
physiological
symptomatic
anemia
in-
present clinically? Present as in, does the mother come and say that, look, my child is getting pale, or any other symptoms?
Not necessarily.
Why not? Means why doesn't it present? So what is physiological anemia? Why does it happen?
Because during fetal period the child is under a hypoxic condition. As once the child is out of the uterus, the child will have the oxygen saturation goes up and the stimulation to the bone marrow get decreased over a period of time, and when it reaches a particular level, then only the erythropoietin stimulation takes place.
Yeah. So therefore, there is no disease state as such. It's just that you don't need that 18 grams of hemoglobin, so it goes down, down, down. So production is kind of at a zero, kind of, till the point is reached where production is stimulated again. So the moment that point is reached, production starts again. So that's why it's never symptomatic. What else?
Considering 4 months of hemoglobinopathies.
Okay, so which hemoglobinopathies?
Beta thalassemia major,
Okay,
alpha thalassemias,
okay.
hair.
So we'll call this as hemolytic
Hemolytic
anemias.
anemias.
Then,
Then consider storage disorders.
okay.
In considering the fact that mother noticed distension in the upper abdomen.
Correct. So now tell me, how will storage disorders present? Keep in mind the age.
Vomiting, episodes of vomiting in the infant there could be episodes of there could be altered sensorium in the history. Then there could be lethargy in the child as a result of hypoglycemia. There could be convulsions.
So a storage disorder which affects multiple systems will present with multiple other manifestations. And a storage disorder which only causes hepatosplenomegaly will almost not present with any other symptoms except distension of abdomen. Means functional derangement will be postponed for some time, right? So a storage disorder coming as anemia with cardiac failure at this age is less likely. That kind of a storage disorder would have probably multi-system manifestations. Okay, what else?
Torch infections in the mother,
Torch infections in the mother.
congenital.
Okay, so can we discuss that? How would you give points for and against? House? Your thought process is on torch infections.
If the child will be, if it is a torch infection, the child will have a history of failure to thrive.
Okay,
which
so
this child doesn't apparently.
So
doesn't
one important history will be how was the child doing from birth to 4 months in terms of feeding, growth, activity, development, all that. What else?
Antenatal history in the mother.
Antenatal history in the mother.
Fever,
What else?
Visual difficulties in the baby. If the mother notices that the baby is not looking towards the direction of light, or
Okay, so
any
some
hearing
affection
disability.
of other areas. Then birth weight of the child.
Birth weight of the child.
Okay. And then the abdominal distension. Okay, abdominal distension is maybe they didn't notice, but it was there right from the beginning, because here you said abdominal distension she noticed after being questioned directly at 4 months. Okay. Any other thoughts on anemia at 4 months?
Infantile leukemia could be a possibility.
Infantile leukemia. Okay. So what are your elaborate on that?
Because the mother says that there were 3 units of red blood and 1 unit of white blood.
No,
concentrated.
don't go by that. See, we are trying to learn that if a 4-month-old came to me with breathlessness, what should I think? Then we said once I narrow down to cardiac, I should think of intracardiac problems and extracardiac, what we discussed. Then we said this is anemia causing failure. Then how should I think on what could be the cause of anemia here? Because white blood was given, you are going to the marrow, that's a different issue as a marrow cause of anemia, right? So, in short, what are the 4 classes or 4 groups of anemia, physiology wise? So, one is hemolytic, one is bone marrow problems, then nutritional or deficiency, and 4th, hemorrhage or blood loss. Okay. So out of these, at 4 months, which ones are applicable?
Hemolytic.
Deficiency anemia can come at 4 months.
Less likely to come.
Yeah, extremely unlikely to present as cardiac failure at 4 months, unless there is a dual or cause or something like that. Then what about hemorrhage?
The patient would have presented as shock at an earlier stage
Very
than
good.
directly presented.
Very
as
good. So either the hemorrhage would be obvious, and if the hemorrhage is hidden,
Rajesh, just repeat what says.
This child has a subdural hematoma. It's a chronic hemorrhage. And it's getting bigger and bigger. You are losing blood there. And you are anemic. So acute hemorrhage is shock. That's acute anemia. What about chronic hemorrhage? 4-month-old subdural hematoma, yes. It was a difficult labor. Okay, some small injury. It could have often presented at 6 or 8 weeks. But yes, this is presented at 4 months.
That child would have CNS symptoms associated.
So it doesn't present as anemia, presents as something else in which you find anemia. So again, what we have learned is presenting feature is so important. Subdural hematoma classically comes as also anemia, but presents for a seizure, and then he is found to have anemia. Whereas this child has come for anemia. So just to make a point, chronic hemorrhages are also known, but they are symptomatic other than anemia, and anemia is often just a presenting thing.
okay,
Also, when we are talking about deficiency, and as you rightly said, that alone deficiency, that at this age, when you think of a picture of deficiency anemia, but probably deficiency alone won't occur, think of this particular child could have had a loss earlier at birth. For example, feto-maternal transfusion, which may have occurred at that time, which may present. He is born with a small, low iron, and at that time everything looked, but he will present with the so-called anemia in an exaggerated form, and of course a very preterm baby would also present with what normally would have not presented in a term baby. So when you have a physiological anemia but it is aggravated, go to these 2 causes, which you may not get preterm, you may get a history, but feto-maternal, maternal-fetal, you may get no history, and then this is to be borne in mind.
Okay, so therefore, what is more likely as a cause is, one is hemolytic group and second is bone marrow group. Okay. Now, anything further within these groups to fine tune?
In the hemolytic group, to see whether the etiology is hemolytic, we'll need to ask other questions like neonatal jaundice, whether the patient developed neonatal jaundice, and history of jaundice currently, the color of urine, the color of stool, and
Usually even hemolytics will not have any changes in these parameters, no? What
blood
else?
transfusions in the siblings, family members,
Okay, so family history.
and
Okay. Anything else?
I think the storage could be only in the bone marrow. We are not talking about the Gaucher's, Niemann-Pick's, etc., which come thereafter involving multiple organs. For example, an osteopetrosis is a storage disorder and is only in the bone. So one can have an anemia, chronic bone marrow anemia with liver and spleen of an osteopetrosis. Myelofibrosis, for example. Again, another example. Generally a sick child, a febrile child, but osteopetrosis is typically a chronic bone marrow anemia at even this age. And that has liver and spleen as well. So we'll keep in mind that if there is an abdominal distension, there is a liver and spleen maybe, and if that is so, it's hemolytic or a bone marrow infiltrative. Bone marrow infiltrative are largely two types. One sick, who are myelofibrosis, primary or secondary, or osteopetrosis, who are not sick. They are exactly looking like a hemolytic anemias on the history and also on examination, unless there is something else to bring out hemolysis, like maybe some hemolytic facies, etc., which take time to develop. Osteopetrosis, you may be lucky to get some CNS findings, some cranial nerve palsy or a hydrocephalus, then you know that that's another way to diagnose an osteopetrosis, because everything that is going out of the cranium can also be blocked. And sometimes they would come with cranial nerve palsies and a severe anemia and a liver and spleen. But diagnosis becomes very easy, a neurological manifestation of osteopetrosis. So I think we'll keep in mind these two. What I'm trying to say is that when you have any anemia, first say acute or chronic. Here it's chronic. Chronic anemia with liver and spleen. So hemolytic or bone marrow, sick or non-sick. So all that is ruled out. What we are left with really a hemolytic anemia or an osteopetrosis for a clinical discussion.
Neuroblastoma is again bone marrow infiltration by malignant cells maybe. That also can present as pallor without there being any abdominal mass that is palpable at this age. So in bone marrow disorder, sick looking children can be some malignancy as well.
I was just wondering whether neuroblastoma will have severe anemia. I'm not sure. I feel probably not. Neuroblastoma will come as a PO and has a bony secondaries. Sometimes you'll just pick up a small nodule on the scalp, which is so easy to miss. But the child is very sick, but the age is fine. They are more often in young infants. So we'll keep in mind that whether malignancies can come in, more than leukemia, such things would be in order.
So we'll examine the baby.
If this particular child has received white blood and red blood, then probably has received platelets also. So hemolytic anemia to produce a significant thrombocytopenia requiring platelet transfusion is less common, and bone marrow disease, that means both the two series are affected, is more likely to be a bone marrow problem.
Sir, we were discussing without that history how to derive. With that history it becomes a little... इधर सुला दीजिए बच्चे को. Right. Anybody wants to volunteer to examine? Come on. Exams are far away. This is the time to volunteer. Come, one or two.
Child is comfortable, not tachypnic, not sick looking.
So with
Pallor.
respect to this history, what all will you comment on inspection? With respect to what we have got in the history.
Breathlessness about the.
Yeah, you said breathlessness, not sick looking. What else?
Pallor present.
Very pallor, which you said. Then,
Abdominal. Contour
okay,
of the
abdominal distension. Then, you know, comment on the growth.
Growth.
On inspection, whether you feel well grown,
Well
poorly
grown.
grown, averagely grown.
Well grown chin.
Okay. You can say averagely grown. Then,
No signs of any hemolytic. Normally,
Okay.
it will not come up in this age.
yeah. So besides hemolytic faces, anything else you want to look at?
No jaundice.
Dysmorphic facial
Very good.
features.
Dysmorphic faces. Okay. Then
Any icterus.
icterus. Then
Any visible swellings anywhere else, like cervical lymph nodes or
okay.
anything. And shape of the head, whether there's microcephaly or whether there is hydrocephaly.
Okay.
Petecure or
Very good.
Petecure.
Petecure. Any signs of petecure or any other suggestion of the third series getting involved? Very good. Okay. Now examine. Touch the baby and examine. So this was all on inspection.
Also a word about something which is normal. For example, the development of the child is normal. So that's an important
roll
observation. Growth and development.
So how did sir know by inspection that the development of the child is normal? Just by inspection?
The child tried to roll over in front of us.
Very good.
which
So
is the
tried to roll
milestone
over.
to be
Then
achieved. He's having social smile and looking.
he is
toward
looking towards the source of sound. Very good.
interested in surroundings.
Very good. And any other field? So rollover was gross motor. Source of sound was sound, cognition. Any other field the child is showing? Mouthing.
Mouthing.
On inspection of the abdomen, there is slight distension of the abdomen in the left upper quadrant. So no visible swellings, no visible sinus or any scar marks. All quadrants moving equally with respiration. On superficial palpation, one mass felt in the left hypochondrium extending towards the umbilicus. The temperature being normal, no superficial tenderness, guarding or any rigidity. On deep palpation, the liver is felt around 2.2 centimeters below the right subcostal margin in the right midclavicular line. Firm, soft to firm, non-tender, margins smooth, contours rounded, smooth surfaced. Left lobe not palpable. Regarding the spleen, the spleen is around 6 centimeter palpable below the left subcostal margin. Towards the, it is firm in consistency. Splenic notches felt, smooth surfaced, and growing towards the umbilicus, non-tender.
Are there any other findings besides?
There's a depressed nasal bridge on inspection, and pallor present. There were multiple lymph nodes in the cervical region, but they were insignificant. And otherwise, limbs were normal and genital examination was normal. Skull and spine was normal.
Okay. Okay, so now discuss in view of your findings, how will you think? Come. You want to discuss, Gautami, your differentials in view of the findings?
Sir, age 4-month-old with anemia with splenohepatomegaly. Spleen
Hepatomegaly is there or not there?
didn't see the liver spleen.
So you didn't see the liver span. So what is it?
6 centimeter. Liver span was 6 centimeter.
6 centimeters. So it's not hepatomegaly, or it is? What is the consistency of the liver?
It's soft to firm.
So for all practical purposes, it is splenomegaly.
Sir, could be an underlying hemolytic disease, but no icterus was presently, and storage disease could be, but it is not fitting in this context because the child is well grown and milestones are well achieved.
Tell us the anthropometry.
The weight of the child is 5.4 kg. It's between -2 and -3 standard deviation. The length is 60 centimeter, between -2 and -3 standard deviation. The head circumference is 39 centimeter, between -2 and -3. Chest circumference is 37 centimeter. The mid upper arm circumference is 11.5 centimeter, between -2 and -3. And the weight for length, it falls between the -1 and the -2 standard deviation.
So what do you make out of the anthropometry? Everything is -2 to -3. So that means this child is malnourished.
Yes, it is so. The weight for length is not much affected as compared to the weight for age and the length for age. So could be a
Very good.
chronic.
So could be what? So we've discussed this again many times, that if weight for height or weight for length is not affected, then the child may not be malnourished. Though your individual reading may show less than -2 standard deviation, so you have to correlate it with clinical signs of malnutrition. It could be that the child is of a small build. Okay, so at as early as 4 months of age, if the length is also below -2, and if the length has gone below -2 because of a disease, then the disease has started long back. So in that case, the weight should go way below. So this is the logic, no?
So both are in proportion. That's why you are not so worried about that.
Okay, so now what are your thoughts on after examination findings?
So the patient is
Louder.
5-month-old male infant presenting with anemia with splenomegaly with no failure to thrive with no developmental delay. So my differentials would be hemolytic anemias, storage disorders, torch infections.
How torch?
And
Why torch
You
infections?
ruled it out. Didn't you rule it out in
Yes.
your history only? Then don't say it, no?
hemolytic anemias and storage disorders. I would like to rule them.
Which hemolytic anemias?
This age group, you could think about beta thalassemia major and alpha thalassemias. Hereditary spherocytosis little less likely. Icterus is not present.
Will they come with only splenomegaly?
Yeah, they could present with just splenomegaly.
Okay. Why is this not just hypersplenism? You have
All
a
the
big
three-
spleen, no?
All the three lineages will be affected. There should be signs of thrombocytopenia like petechiae or.
So all the three to will come to know after we investigate. We have not investigated. All three need not be seen clinically. But the first question is, do you need all three affected to diagnose hypersplenism?
2 cell lines at least.
Two, no? So two are there, no? History is there of giving two blood and white blood.
Rajesh, what is white blood?
Platelets.
Okay, okay.
That's what they equate it to.
It can be plasma also.
I had asked the mother about the blood product, how it was, whether it was frozen, whether it was cold, or whether it was a normal temperature of paper. I asked her, and given her description, it was probably a platelet concentrate. Though we cannot be sure of it.
Yeah, fair enough. I'm just asking.
So what about hypersplenism? Come on. So first of all, hypersplenism is not the primary diagnosis. Spleen is enlarged due to whatever ABC primary pathology, and then because it is enlarged, it may overfunction and cause hypersplenism. So you still have to argue or find out what is the primary reason for splenomegaly. Hypersplenism is not the reason for splenomegaly. And the second thing is that it is very uncommon for the cell lines which go down to be clinically symptomatic, and platelets almost are never symptomatic, and even anemia will not drop so much that the child will need a blood transfusion. So that's not your primary thing. So it's more of a lab diagnosis or a additional component to whatever rheumatological derangements you have. Okay.
Why is he saying that platelets are not manifest clinically? If platelet count drops, she should bleed. Why is he not bleeding?
In hypersplenism, Anand is asking, if platelet count drops, why do they not bleed?
Wrong question.
They are all functional platelets.
Okay, so platelet function is not affected. Very good.
Can it be any of those infections? Fever may not have come.
So why not just malaria? Commonest cause of spleen, no? And pallor.
There's no history of fever, and the behavior of the child was not like a sick
No.
child. It was
So
feeding.
infant, no, may not have got fever.
So if it's acquired malaria, you will think of fever, but if it's congenital malaria which is going slowly, child will not get spikes. You got the difference, no? If the mosquito is bitten after birth and then there is parasitemia, you can get fever, but congenital need not have fever.
They will
Any other thoughts on anybody else?
They will not present in failure. Yes.
It will not present as failure. So it is not the only the malaria doing it. So you have 2-3 components. You have physiological anemia, then over and above if you have anemia due to malaria, then over and above you have hypersplenism, maybe. But I thought the child was looking too well, and that's why I thought malaria is a possibility, considering that the child was looking too well. Sir?
In any case, there's one question from the net. Can we take it? So there's a question saying that to diagnose hypersplenism is bone marrow essential. And I think you clarified that point, that two cell lines depressed with splenomegaly would make you think of hypersplenism, and bone marrow is not mandatory.
I think if you see a spleen like this at 4 months, your first diagnosis should be malaria really. That's the commonest cause. And a congenital malaria, maybe 4 months is getting little late. A 2-month-old baby will look like a thalassemia measure, but for early presentation. And at that time, if you do an HbF is also high because the HbF has not come down to normal. And I recall a child who was malaria only, but HbF was some 30%. So they said, no, HbF is high. But HbF has to go down slowly. So malaria and thalassemia may look very alike in an initial time. This 4 months is getting little late, but that should not take us away from malaria. The other common cause of a large spleen is really a pre-sinusoidal portal hypertension. He has not bled as yet, and therefore if there is a bleeding, of course, the whole diagnosis becomes clear. But pre-sinusoidal portal hypertension will just come with spleen. What is different between pre-sinusoidal portal hypertension and malaria? A pre-sinusoidal portal hypertension presents as a lump in abdomen, which is a splenomegaly. Whereas a malaria does not present like that. Malaria presents as anemia. So this child has anemia as a presentation, and the pre-sinusoidal portal hypertension will have anemia only if you have a bleeding. So this is not a pre-sinusoidal portal hypertension, but just keep that in mind when you see a spleen. I think malaria stands in this child.
Sir, there is
Multiple combinations.
there is a question that HbF is supposed to protect against malaria, fetal hemoglobin. So how do these children get malaria then?
Yes, the point is that if there is a mother who is suffering and mother is not being protected, then you get the parasite straight into the fetus. So manifestations are exactly what is said, not like an acute malaria. And therefore they come as a chronic anemia with a splenomegaly. So that's how, when you talk about TORCH, really in India TORCH should be not really TORCH, but malaria, TB and HIV. Those are our congenital infections. TORCH is what the Westerners keep on talking. But if you are talking about congenital infection, TB, malaria and HIV are much more common congenital infection. For example, a congenital TB comes with liver and spleen, but not with anemia. I think we will keep malaria in mind. But how will you push your thalassemia? You will have to tell me about the family, the type of family pattern where thalassemia is common.
Sir, there is just distant consanguinity and there is no family
Nothing
history.
much. And therefore, then you keep that also in mind, surely, but a little less. I would say malaria first, with multiple other contributory factors, like he said, and to rule out hemolytic anemia. Yes. When you talk about hemolytic anemia, you also make a strong point that this is without jaundice. Now, hemolytic anemia without jaundice is almost always just one, and that is thalassemia. Because spherocytosis generally would have a jaundice there. So, if there is no jaundice and a hemolytic anemia of this nature, thalassemia major comes way up on that.
The other name for spherocytosis is familial acholuric jaundice. Okay, so it's familial and because jaundice is what is stressed there. Sir, whatever cases of pre-sinusoidal extrahepatic portal hypertension we have seen, number one, they are little older and they have not such a big spleen
yeah,
at
the
that
size is a bit
1-2
smaller.
centimeters when you don't think of portal hypertension, and anemia comes only when they bleed. So here malaria and of course
Yeah, so in
thyroid.
this child, extrahepatic is ruled out for these
Just to
3-4
bring
points.
to your
yeah.
notice that it could always be a little older child, a little smaller spleen, becomes anemic after a bleed.
Okay, so tell us the investigations in this child.
I think in an exam, also ask whether you could examine a mother or a father around. Spherocytosis is diagnosed by examining the parent. It's an autosomal dominant disorder. And you can see the parent also, they are short. So, if you have a short mother standing by the baby and you have a mild icterus on a spleen, you will make that shortness of the mother and ask the examiner, can I palpate her spleen? I'm sure you will get 10 more marks straight on. Okay, because you don't miss out the surrounding to see whether you can make a diagnosis.
First, like to do a complete blood count with the peripheral smear examination. It would be useful to look at the RBC morphology, the WBCs, again, whether there are any atypical cells, any blasts.
You'll have to speak up, please. We can't hear you.
I'd like to do a complete blood count with the peripheral smear examination. First, to comment on the morphology of the RBCs.
Has it been done?
Yes, sir.
You have the values, so tell us the values and interpret them.
This is a CBC performed on 26th of November. Shows the hemoglobin of 6.2 gram, WBC count of 5,700, platelet of 5,000 on the counter. The indices being hematocrit of 16.7, mean corpus kilo volume of 80.3, mean corpus kilo hemoglobin of 29.8, and MCHC of 37.1, and the RDW was 46.7. On smear, the RBCs there were hypochromic, microcytic, occasional macrocytes. There was anisocytosis. There was polychromasia appreciated. And the differentials for the WBC count, there were 12 polymorphs and 82 lymphocytes. There were 2 monocytes and 2 myelocytes. And platelets were reduced on smear. There were 7,000 on smear.
So when you see a platelet count of 5,000, what should you do? Means when you see a report showing 5,000, what should you look on the report and what should you look at the patient?
We should look at the MPV value in the report, the size, which can help us comment on the size of the platelet, whether they are large platelets. And in the smear, we should look at the size of the platelets, whether they are granular. And
What will it tell you?
they tell that it's the bone marrow is in a state of active functioning, that it is releasing platelets into the periphery.
Would you also want to know how the blood is collected, where it is stored?
Yes, and it would like to know if it's an EDTA smear or a smear directly from the drop of blood.
Excellent.
EDTA smear would distort the morphology of the platelets.
Yeah, and also
And
there
the
should be
counts. Distort
and
the
there
counts.
should be no discrepancy between the platelet count and the platelets on smear.
That's what. So you have to correlate it with the platelets on smear. That large platelet and all you said tells you about marrow. But how else can you correlate the count with the smear? The count. Anybody? You all are science people. You should be pat. So one platelet in one high power field equals 10,000 count. Okay, so roughly. So you should correlate all that and that's how you will come out with.
And why do you want to do that? Automated chambers are there, no? Far better than what your perception is.
Because
How
They can count microcytes as platelet.
They take us
Give a false normal count of platelet. So
they take the size of the cell into account. They actually do not identify what cell they are counting. So there could be discrepancies if there are cells of different sizes. There could be RBCs which could be counted as a WBCs. There could be microcytes which would be mistakenly counted as platelets.
So automated chamber recognizes not platelet, WBC or RBC, but it recognizes the cell size. And smaller size is called platelet. A medium size is called RBC and a bigger size is called WBC. When you have a microcytosis, RBCs are small, so the automated chamber calls it platelet, but that's only when the high count is there. When it's low count, that is not really an issue.
So when low count, these are the issues to look at a spuriously low count. So whether there are technical issues, EDTA, microclots in the blood transported from one place to another. So correlate with the smear and correlate with the patient. If the patient is comfortable, no petty nothing, then you would like to recheck that 5,000 or whatever count. Okay. Anyway, so that's that. Then how will you interpret this CBC? RDW you said is 46, means it's very high or it's low?
We use a different standard here. It's
Correct.
Not
So specify that, na?
so for our lab, this is within the normal range.
Correct. So your SD and CV. So you have to specify which one you are using. So for your lab, this is normal. Okay. Then so how do you interpret this CBC?
One moment, Dr. Rajesh, just make this clear why this is normal for their lab, and I didn't understand CD and all that.
So there are, you tell them, you tell sir. Come on, someone from science should explain this.
CV and SD in in CV, if we see the coefficient of variation, it will be in percentages from 13 to 15, 17 is the normal, and beyond that we say it is inoisocytosis. And in SD we see the standard deviation, that is it is done in femtoliters normally, but here it is normally it is up to 36 to 42. We say it is normal, the normal value normally.
So two different units or ways of looking at the RDW. Okay, so how do you interpret this report?
There are two cell lineages which are depressed. The hemoglobin is low and the platelet count is low. Then
So is there, from this report, can you say whether there is hemolysis with respect to RBC? Then can you say whether the marrow is normal from this report?
there is polychromasia appreciated on the smear. So that means that there is a production of RBCs from the marrow. So the
Very
marrow
good.
is active.
Very good. So reticulocytes are there, so that's a good thing.
And can you also say whether the platelet count is low because of decreased production or increased destruction?
So
Again,
she
there
said
is
that
large platelet.
she said look for large platelets and all that.
The on
So-
smear we are not able to
Yeah,
appreciate.
means you're not able to appreciate, but you said that you look for all that. But this is very important. Polychromasia is there. Okay, yeah. What else?
Look at features such as of hemolysis, fragmented RBCs.
Which are not there. Then what else in RBCs which will
We would-
point to
We
hemolysis?
look for a dirty picture on the smear for anisocytosis, poikilocytosis, all shapes of RBCs.
So the RDW itself,
Itself
no, you
would
said
be,
the RDW
wide.
would be wide. What's the RDW in thalassemia?
Thal major it is wide, in thal intermediate, thal minor it is normal.
So thal minor normal, iron deficiency RDW increased, thal major widely increased. Okay, so that's fine. Okay, go on. Other tests.
Rajesh,
Sorry.
I need your comments on MCHC. You made an interesting measurement of MCHC. 37.6?
37.1.
37.1.
I missed that. Sorry.
No, sorry. Since we are talking about spherocytosis, high MCHC would be in which conditions?
Hereditary spherocytosis.
And sometimes in sickle cell as well, you get high MCHC, right? Since we are talking about lab errors, what are the suppose you get MCHC high in a sample where you are not expecting it to be high. What would you look for, or what steps would you take? What could be the reasons for that? So high lipemic serum can give rise to it. Sometimes if the sample is stored at a cold temperature, then you can have erroneously high MCHC. Okay, and sometimes cold agglutinins also can interfere. These are the three, what I remember at least on this.
Go ahead. What else? What other tests you want to do?
I would like to do a liver function test to look for, even if the child is not showing ictus, we would like to have a look at the liver function test for the bilirubin. Lactate
So liver
dehydrate-
function test means you want to look at everything, albumin,
Everything.
protein, everything.
Serum bilirubin.
serum bilirubin,
Okay.
and indirect component and the direct component.
Okay. Then
And
CBC also we should look for the reticulocyte count for any evidence of hemolysis.
retic count.
Yeah.
Then
then LDH levels, which are an indicator for hemolysis.
then
Then
so you've got this CBC, no, in this child. So now what next?
like to do
whatever.
a HPLC.
Okay, you would like to do a Hemoglobin
hemoglobin
electrophoresis.
electrophoresis.
So have you got a clue that this is hemolysis?
Dr. Rajesh, sorry, there was something about the differential, no? Some 82% lymphocytes or something?
Yeah, 82% lymphocytes, 12 polymorphs.
So that has also to be interpreted.
So what's the absolute neutrophil count?
684.
684. So is it neutropenia?
I think one defect that comes again is that if the samples are not immediately checked, the polymorphonuclear leukocytes, they lose those cells and look as one blob of nucleus, which is called lymphocyte. So in this child, I won't really worry much about that. I know that 82 it looks too much for lymphocytes and the polymorphs are so small number. But in which condition do you get it at this age? Normally also the lymphocytes are a little more at this age than polymorphs. You would have been happy with 60, you are a little concerned with 80, but that is all. I won't give a lot of significance to it in interpretation, but point that is making is we make a note mentally that lymphocytes are too large number and we are little unhappy. We did not expect it, but sometimes that would be the only cause. We might not at this point of time take it very seriously.
Anything else has been done on this baby?
So there has been a hemoglobin electrophoresis done. It was done before the child came to our hospital and it was in a post-transitional state. So the impression was there was no evidence of beta thalassemia, but the report is not reliable because it was a post-transitional state in which the assessment was done.
It's the donor's electrophoresis.
Okay. So now what do? This child was transfused here also, no?
Yeah.
So now what do?
Examine some being who has not been transfused.
Like what is sir hinting at? Can you examine the parents?
Yeah, examine the parents. CBC, the complete blood count of parents with the peripheral smear to look for the morphology of the RBCs. We could do a HPLC on the parents and see whether they are any trait or they are having.
So now what will you do for this baby now? You want to do any more tests? You want to wait?
Since there are two cell lineages affected, we would like to do a bone marrow aspiration with biopsy to.
But we already said that bone marrow seems to be working fine. So why you want to do a bone marrow? That's the purpose of trying to find out from the CBC and peripheral investigations that if bone marrow is working fine, then why you want to do a bone marrow? That's the whole idea of trying to determine that, no?
Have you done a bone marrow?
Yes.
You have.
What does it show?
So it showed a hypocellularity in the marrow. Showed 80% of blast cells and 2 metamyelocytes, 5 polymorphs, 3 lymphocytes and normoblasts in all stages, early, intermediate and late.
Can you speak distinctly? We get confused with what you say.
There was hypocellular marrow with normal fat spaces. The marrow was packed with blast cells up to 80%. There were other cells like metamyelocytes and there were polymorphs 5%, lymphocytes 3%, and there were RBCs there were normoblasts, early normoblasts, intermediate and late normoblasts. 2%, 6% and 2% respectively.
Okay. So now go back and tell us that what means after that CBC, what should we have done? This first CBC which you told us. What should we have done?
Re-examine the peripheral smear for the how the WBCs looked for any atypicality.
No. See, what I meant is we discussed that 5,000 platelet count. Now we said we have to cross check whether it's spurious or whether it's really low. So we discussed all that. Plus you would reconfirm it with another sample, right? And if that 5,000 persists or that low platelet count persists, we discussed whether there is any evidence of normalcy of marrow by way of large platelets or by way of reticulocytes and all that. So if that, you said on this smear you couldn't make out whether you couldn't appreciate the platelet or large platelets and all that. So you probably repeat and reconfirm, and if that still is there, that you are not able to see large platelets, not able to see clumps, then you are not convinced about the normalcy of the bone marrow.
Same way confirm the lymphocytes which are high.
Same way.
So
So whatever we have, these were technical explanations, but you need to reconfirm and check, and then if the abnormality persists, then obviously go for the marrow also.
I think sometimes in a leukemia, because there is a stimulation of the bone marrow, after all the blast cells are there, and the rest of the series may even look like coming up, stimulation. For example, typically happens in a remission. If a leukemia is on remission and suddenly gets again a relapse, the first way to know relapse is a normoblast in the peripheral smear. Because when bone marrow is stimulated by anything, stimulated by even the blast cells, suddenly the RBC series also start coming out early, and a normoblast which might look like a hemolytic process. So the point is, sometimes we might mistake a normoblast or a retic even in a leukemia, because after all, what does that mean? There is a hurry on the part of bone marrow to push out a premature cells. Where is the hurry? One hurry is if there is a need. Another hurry is if there is an irritation of the bone marrow, then also there is a hurry. And therefore, we are looking back, we are looking like hemolytic process. Okay, some areas look like yes, retics, but some areas did not look like. I'm sure that if this was confirmed again like platelets low and lymphocytes high, the only cause of a high lymphocyte really is the leukemia. But in this child, symptomatically, etc., we would not have thought of it, because the story looked like a chronic anemia, story looked like a cardiac failure. So what we knew was that there were multiple components of anemia, and that together caused a cardiac failure. Which leukemia comes as cardiac failure? No, leukemia comes as cardiac failure, but multiple contribution. So looking at the child who is not sick, we said this child has 2 or 3 reasons for anemia. One was malaria on our card. Another, he said, maybe neonatal some problem like transfusion. Another is a deficiency added. Okay, now we understand now that this also leukemia must have had other contributions to anemia, and a leukemia as well came. No leukemia to my mind comes as anemia and cardiac failure. A chronic anemia, chronic leukemias also don't come as cardiac failure. In fact, typically if you look at a CML, they don't have anemia.
In this child, probably the leukemia has not contributed to the anemia at all, because even now the marrow is showing normoblasts and all that, which means that the RBC series is not much affected as yet.
Yes, because you have an anemia there. But my point was that when WBC series are loaded with those blasts, there is an irritation of the other cell lines also. And sometimes you might get a normoblast there, but still they are anemic.
Sir, on the marrow, often they say that there are islands of hypo and hypercellular in leukemia, and therefore there may be islands of hypercellularity which are pushing the normoblasts and the reticulocytes in the peripheral smear, giving us an impression that it is not a poorly functioning marrow, and that is why sometimes you may have to do even a biopsy to find out this particular child. But even then, the clinical picture of a slowly probably Rajesh, the cardiac failure was because of anemia.
Cardiac failure was because I am saying, sir, that the fact that the leukemic process has not yet totally subdued the erythroid production. I'm saying the anemia was due to the other reasons which we discussed and not yet due to leukemia. I'm just saying that. Anemia obviously was there and it
And
caused.
often commonly put argument that this is perhaps not leukemia because it is not a sick child. There may be a short gap between a sick child and a non-sick child, sir. A 7-year-old girl was brought just because she was not eating for 2 to 3 weeks, and all that she was she was anemic, and there was a 2 centimeter spleen, and then she was playful, and there was no reason for me to say, but I said this particular child last time I saw did not have spleen, so I want to rule out anemia, maybe because of malaria or whatever it is. But because the parent insisted, no, whatever investigation you want to do, you must do it today only because we are going abroad tomorrow. So reluctantly I did a CBC and it was loaded with blast cells. So a sickness would have come had I waited for another 10 days. So even in a non-sick child, we should be ready to entertain a malignancy.
I have a question for you, Dr. Nikila. What made you all decide to do the bone marrow? Because of the 2 cell lines.
2 cell lines were involved, and we're not able to reach diagnosis.
You could not find a
No,
cause.
so
Because
we
that's
had to
interesting.
In fact, this is 3 cell.
No,
three
sir,
cell lines
sir,
here.
Actually,
One
their
abnormal cell.
2 cell line were the anemia and the platelets.
Yes.
The WBC is a subtle cell line involvement which is to be fished out kind of.
And there were no blasts on the peripheral smear.
But there were abnormal lymphocytes on the peripheral
There
smear.
were atypical lymphocytes reported, like we had run 3 CBCs in our lab, and once there
So
were atypical
atypical
lymphocytes.
itself means not typical, means not necessarily normal.
No.
No, but I mean, that's exceptional that you thought of doing a bone marrow. We would not have done it the way the baby is presented, maybe much later.
The only thing one would have repeated, and if lymphocytes were high and platelets were low, we would have done that. Okay, but at first stage when you saw the lymphocyte, I was wondering whether there's some malaria, and leukemoid reactions are known in many infections. Okay, and I would have said, no, it's not leukemia that I'm suspecting, but yes, some leukemoid reaction. So just last question before we take the next thing is, how do you differentiate leukemoid from leukemia? Leukemoid reactions are seen in many chronic infections. TB, for example, comes with lymphocytic, monocytic, eosinophilic, any kind of leukemoid reaction. So any thought on how to differentiate between the two? Both look like high counts. Lymphocyte high count is leukemoid or leukemia. In this child I was ready to call it leukemoid because he was not sick, etc.
How will you differentiate? Come on, anybody? Take the mic.
WBC counts are very high in leukemias when compared to leukemoid reaction. And leukemoid reactions, you have child presence with fever, and the child is sick when compared to leukemia. Leukemias are need not present with fever, and
See, but very high doesn't have a definition, no?
1 lakh.
So for,
was-
no, 1 lakh, but 1 lakh was 40,000 someday, no? So 40,000 and 1 lakh. So any better difference?
And you know that leukemia also can present with low count. In fact, one of the parameters to judge the prognosis is the count at the admission, count at onset. So you can have even a leukopenia and a leukemia there. So we take your point that if it was 1 lakh, yes, but even a leukopenia could be a manifestation of a leukemia. So have you heard about a leukocyte alkaline phosphatase? That differentiates between leukemoid and leukemia. So there is a biochemical test that is done. Of course, some of the points that you made, less sick, more count, less count, yes, in general, but that's not certain.
Sir, would you like to do a CT abdomen here to still rule out a neuroblastoma going leukemic process class 4A or something like that? Because the symptoms have not presented with fever.
I mean,
and all.
largely whatever neuroblastoma I've seen, the PUO, they are sick children with fever of unknown origin. And you are looking at a diagnosis which is just not there. And the first diagnosis clinically is really a metastasis often in a bone. And somewhere small metastatic nodule which is easily missed. So I think to me they are very sick children, but even a leukemia should be a sick child, but not so sick. Neuroblastoma is a very sick child. But I suppose if somebody has seen 100 neuroblastoma, he would see one without sickness. So
You said 3 CBCs were done. What did the other CBCs mean? Generally, they were also low platelet and
Low platelet. There's an improvement in the hemoglobin because we had transfused the child on 6.2. So the CBC following that was 8.1. Counts were the same, 5,700. And platelets also, we had given one pint of platelet concentrate, 13,000. So it wasn't greatly improved.
and the lymphocytosis also.
Lymphocytosis also was persistent. There were 74% lymphocytes on the following CBC.
74 is okay actually. I mean, you wouldn't really.
And why did you give a platelet transfusion? Because you wanted to do bone marrow.
No, because it was 5,000.
5,000.
5,000 is an indication for platelet transfusion.
Actually, it
Depends
was,
on how strong your heart is.
Okay.
Yeah, I mean, you're right. It's a debatable issue.
No, I'm just so that we understand.
See, you're right. Theoretically, everyone says that unless there is bleeding, whatever be the platelet count. But practically, not everyone has the courage to go on waiting beyond a single digit 1,000 figure.
I think we will end up this case, and today we will have some different way of using another 30-40 minutes. So we will have one counseling session and one history taking session. Okay, quickly, 2 volunteers for either of the two. Come.
Thank you, sir. Come on, it's going to be an easy one. Don't worry.
Come, not the usual ones. I want some unusual ones to come forward.
The ones who want to pass in first attempt.
Yeah, and Anand always says, those who want to pass first attempt, please be here first. Nobody wants to pass first attempt. What's wrong?
All of you must have passed. That means then only you are not interested in passing again.
Come on, somebody, come on. And we are looking at very simple, basic. Okay. And this
Okay,
is
I'm
the
gonna-
place. This is the place to make mistakes. See, we did not think of leukemia in this.
I'm going to leak the paper
What is
now.
the shame? No shame. Okay. Yeah.
We are going to discuss counseling on a child who is diagnosed with rheumatic fever today, and another counseling will be on a child who is diagnosed with leukemia, since we talked about leukemia today. You can convert it into how to break the news and counsel, or just counseling on a child
Come
with
on,
leukemia.
yeah. What is this?
Come, would nobody come? Then they are all ready to come. Huh?
No, we can counsel each
Yeah.
other. There is no problem. All of us, all 4 of us, we can do that for you.
But we need counseling to counsel.
Come, they want only you to pass. Come. Come. I'm sure it's so easy for you, but also make them feel that it's so easy. So come here.
So let's start with the scenario that we saw just now. So how will you counsel these parents about the clinical suspicion of, say, ALL? If you have suspicion of ALL on on CBC and this, that will be the case scenario. Bone marrow has not yet been done.
We'll just tell them that we are suspecting a disease of blood.
Consider I am one of the relatives and you can counsel. Nowadays you can counsel in English also in exam. So feel free to choose a language. No, you have to say I am your treating doctor, and you can use your name. In exam, some people are sensitive. You don't want to use your name. You can simply say I am your treating doctor or pediatrician.
Yeah.
Hold it closer to you.
I'm your treating doctor, and so do I have to?
Feel free. Do whatever you feel like. What would you do tomorrow when you go for rounds to the patient? Mother asks, "Kya hua hai bacche ko?" So what you will answer?
We are not very sure that what specifically the disease is, but we would we think that it is a disease of blood. So for reaching to a particular diagnosis, we need to do a test which is which is an invasive test, and we'll need your consent, and we'll need your approval for the test. It is called bone marrow aspiration, and we need to put a needle into the that will require us to put a needle into the
Try to
the-
make it as less traumatic for the parents as possible. So whenever you are
we'll
discussing,
just put a small needle in the child's hip
Sorry
bone.
to interrupt, but see, you're not explaining a procedure. You are counseling the whole process. So needle and all is intricacies of the procedure. The focus is not the procedure.
yeah, so Rajesh, because I told her that we haven't done a bone marrow yet, she's probably trying to counsel the
sorry,
parents saying
sorry.
that I would want to do a bone marrow. If on the other hand, if you have a bone marrow report and you are counseling, then the situation probably slightly different. So I agree with you. I would have probably told her that this is the reason for doing it. You have to explain what happens if you don't do the test for any given test. Okay, what can you do without the test? How will the test help in diagnosis, prognosis, complication, etc. So that you can answer.
So,
What are the side? What is the how? What is the what does the procedure involve? What are the immediate post-operative management that you observation that you want to do, and what are the side effects, if any, of that particular procedure?
Yeah, I'll just and I'll tell them that the procedure is invasive, but we'll make sure that the child does not feel any pain. We'll sedate the child during the procedure, and it will be the procedure will hardly take 30 to 40 minutes, and the child will be sedated for maybe 1 or 2 hours.
Okay.
Go
ahead. Go ahead.
The procedure, we want to do this test mainly to exclude a disease of blood, mainly
No,
blood
so
cancer.
try to avoid using the word blood cancer because you don't have a diagnosis. You say that whatever tests we have done from blood that we can collect from other sites have not given us a conclusive diagnosis. So we want to go back to the source to find out where the blood is produced, what is the problem, and that is very important for us because the baby is not forming blood and we have already given a transfusion. So in the periphery there is a blood which is mixed with somebody else's blood. So we want to go to the source. That's one of the way of telling it. Okay.
Yes.
So then after the procedure, baby will be given some medication and we will come back to you as soon as the reports come. The first report we'll get it, like suppose you are doing a bone marrow aspiration. The first report we'll give you on the same day, and the biopsy that we will collect will give you a report within few days time. Okay. So that's something like you want to convince or yes.
You started with the first sentence, we do not know what is happening. Now you must tell what is happening first. You projected confusion right in the beginning. Okay, so we know that this particular child has less blood and his hemoglobin has fallen down significantly apart from
you
platelet.
said I am your doctor.
Yeah.
We have examined your baby. We have done some simple tests which show that this baby has less blood. Then as we discussed in the beginning, you could say that less blood can be largely for 3 reasons. Either blood is lost, or blood is getting destroyed, or it is not formed. It is not lost that you can make out. From our tests it doesn't show that it is being broken down. So we are suspecting whether is it not being formed properly. We want to reconfirm that. So we have to do this. So you build a story to come to why you want to do that.
And also connect the blood with bone marrow, because otherwise say kahan darat kahan ilaj. The blood is formed in
Yeah,
bone
you need to
marrow.
tell them
Like
that
you
it is
said,
formed
and
in the
then-
bones.
So now we have a diagnosis of leukemia. So now you have got the bone marrow report and you have to counsel the patient, break that news and counsel, or just counsel the patient. Anybody else wants to help her? You can have two
No,
people
but I
coming.
thought you did a great job
Yeah,
for an
I think so.
extempore attempt.
Absolutely.
Well done. But don't go. You might, if
Don't run
nobody else
away.
comes,
Yeah,
you
now
will.
that was the first time. Now you are an experienced contender. So, no, this is the easier part. Believe me, counseling for a patient whom you know that the diagnosis is ALL is going to be an easier part. Imagine yourself in the ward and talk. Don't worry about the steps and
Come on, why don't
See,
one of you come here? You work in the wards, na? Tomorrow you'll have to talk
did,
to the patient. See, when
we have-
someone is coming.
no,
So,
no, it's okay. You start. She will help you out.
Yeah.
She can pitch in.
So we, I mean, we have done the bone marrow examination today morning. Now we have the primary report. The smear, the report which we have examined is suggestive of a disease of blood, where there is
Yeah, we all worry about how to say the word, right? So that's what you want to talk to them. That's how you have to learn.
I think now there is no harm in saying.
Absolutely, you have to say the word. That's how to say it. You say
Now
that
you
we were suspecting a problem.
we have to tell you that it is a type
Yeah,
of blood
unfortunately,
cancer.
your blood report shows that there is cancer of the blood. What next will you say?
But it's you should not start thinking that it is not treatable right
Absolutely,
now,
very good.
because we need to do certain more tests. We need to go for the cytogenetics, and we need
That's
to go
okay. You
for
don't have to specify
we
exact
need
words.
to go for some
Yeah.
more investigation, which will tell us that if this kind of blood cancer is treatable or not.
No, it's always treatable as far as you are concerned. Not me. You say that what
Yeah.
kind of treatment to adopt to get best response with minimum side effects will be determined by the subsequent test that we will perform.
So after that we can wait for some time, tell them that if you want some time, you have to
Yes,
sit down.
very good.
Some water.
Yeah. Okay. So also you will also tell them that this is one of the cancers which is
Treatable.
totally treatable, and in
We have
majority
seen
of
many
the
kids
cases,
who
yeah,
have been
in our
treated.
center also we have got
They
very
have
good
responded.
results, and
They have responded.
this is one of the best
Mm.
cancers to have, if at all any. So
After that we'll then this will be a long, means this is a little chronic disease, so you have to be ready for continuous follow up, and
Very
you should be they will require some blood transfusions or some this thing, so you have to be ready for that, and you have to be strict in follow up. They will require regular
So when you
CBC,
give them
so
a
you
good picture, you always underline it with something saying that most of them don't have a problem and they become all right. But by that, on the way over there, we might come across some hurdles, some potholes. There may be some falls and minor injuries, which we will help you along the way. And
counsel them for a recent, means child will be pricked, like they should be ready for that CBCs to be taken
correct. So
regularly.
that's always been a challenge. So to agree that in one counseling, if it's an exam, you will have to probably cover everything under the sun. And you want to talk about what medicines will give, put a port, give intrathecal, hair will fall, what complications might occur, multiple transfusions, platelets, expensive, social worker. All this will have to be said if you are talking in an exam. Okay, because in that 5 or 8 minutes you will have to cover many points. But if you are talking to the parent on the first meeting, there's absolutely no need to talk about any of these, because as you rightly said, you yourself are feeling uncomfortable to talk about it. You have given them that news, let them digest it, give them some time, tell them to come back, meet again, say we are always around. Whatever new questions you come up, you can talk with it. General frame, apart from this, you can also talk about money, saying that it's an expensive treatment, but we have enough people here to help you, and whenever we are short of things, if you need, we will try and get you help from elsewhere. Is there anything else you?
I only hope that the examiner says that you are meeting for the first time, counsel. Because otherwise it's so difficult. Yeah.
Usually the scenario.
Yeah, because otherwise it's difficult. If I see a leukemia, I will not even break that news suddenly to shock them. I would just say that, look, we have confirmed that this is a cancer of the blood, but this is very much treatable. Okay. All that we need you to follow our treatment properly. We'll be giving some intravenous drugs, we'll be giving some oral drugs. Well, every drug has a side effect, but we know how to minimize side effects and to get the best out of the drug. So don't worry about it. Almost always this leukemia gets controlled, it goes into remission, they remain well. Don't have to say, but they may relapse thereafter. You don't have to say that. Because after all, ALL will have a good thing. Not every time it will be a good thing. You don't have to say that they will go into a crisis when you get into a uric acid will increase. So I would say that, but of course as the DNB exam stand, some keyword will come and say get social worker on, get. I feel that may be really not
Yes, sir.
fair.
So I totally agree with you, sir. Only thing, just like in Down syndrome, even with leukemia or nephrotic syndrome, your scenario given in the exam will be reasonably specific, not as specific as said probably, and the answers you won't know. But if for example, leukemia can be asked in a very in a totally different way, saying as a case scenario of breaking bad news. Okay, so now you have to break this bad news to the parents. So there you may not really go into the further treatment of delay. The count will be on eye-to-eye contact, empathy, how much time you are giving, do you have any more questions, we will connect you with other people, you are not the only one in the world, lot of people have it, vagera vagera. You get my point? If it is about diagnosing leukemia, then what we discussed about bone marrow and all those things will come. If it is about a known case of leukemia, you counsel about treatment and prognosis, then all the other things that we talked about. So because in 8 minutes you don't expect them to cover everything. Similarly for Downs, you can have antenatal counseling for Downs, you can have newly diagnosed Downs, you can have a 8-year-old or 10-year-old coming with Down syndrome, where the counseling will be different. Thank you, you've done a good job. One more?
You can stay back. He is giving you one more. Yeah.
History you want to do?
You want to do history? Okay. So we'll just do one more counseling. I think that's more interesting. So we'll start with the scenario like this child is been diagnosed with acute rheumatic fever with moderate carditis. Okay, you have a specific diagnosis now with you, and you have to counsel this patient now.
Okay, well, see, I'm not treating doctor. We have done, you've brought the child to us. We have done some tests and we found out that first we'll have to explain that what kind of pathogenesis this disease has. So
Very good.
we'll explain that there are antibodies produced in.
No,
They won't
tell
understand
what you're talking
antibodies.
to them.
Yeah.
Whenever we get an infection, like we'll ask this, he had fever or joint pain or something. So when he had that infection, body tries to fight back. So they produce some substance against to fight it. It's known as antibodies. Sometimes what happens is the antibodies attack our own cells, means our own body cells, which are not supposed to attack. So he's having this kind of a problem, which we have seen in other patients as well. So it's not new, but it has happened in your child. So that has actually caused this problem. We have done some tests.
Which parts? Where all does it affect? As a father or parent, I would ask.
So it affects the joints, but sometimes also affects the heart. So this has happened that it affects his heart.
How did it happen to my child? Sorry, I'm interrupting you. You're going with a good flow.
Yeah,
but just
don't worry.
filling the
This is
blanks
not
right
something
now.
that is that's come from your family or something. So don't worry about that. Everyone is fine. This is something which is acquired as a, like we say, we acquired infection from somewhere. This is just happened like that.
No, but this is not an
No,
infection.
this is not
You
that,
said.
yeah.
You talk about previous streptococcal throat infection, etc.
So he had.
If at all.
Yeah, it's previous infection.
Okay, fine.
So I wanted to ensure that sometimes they feel that it's big hereditary or something. So it's
No, that
not
is fine. That's a guilt removal, no? So that point you want to address.
So we
Now
have
what
done
will
some
happen to my child?
tests which have shown positive for it. So he is having this problem, and it has got some amount of effect on his heart, which we have seen in the reports.
So you dealt with pathogenesis, you dealt with guilt removal and the diagnosis. Now what you want to talk about is immediate treatment.
So immediately we have given him medicines and all to stabilize him. He's doing fine. But you have to understand this is a disease which will take some long time. It can again come back or something. You need to take treatment for some time. You need regular follow-ups. You will also require injections like prophylaxis for penicillin and all, which will have to come regularly. And we'll have to do regular sonographies of the heart and tests to see that the damage means it's coming down or it is staying the same.
Okay. So here you can, if you are given only on management, and prognosis. You can give some details about aspirin, about penicillin, how much rest will you take, because that's what they are interested in. When can you start regular schooling, if any extra vaccines are required, what treatment you are going to advise after going home, how long you are going to give. If it is penicillin related, then few things you may want to talk about penicillin, its possible allergy, and so you should take it in a place where facilities are available to handle it.
Yes,
Okay. Also about red flags. So whenever you ask somebody, for follow up. So when you are going to call them for regular follow up, when are they going to come out of turn for follow up? Okay, I'm trying to give you a template which will apply to most of the chronic condition. So if you have to come for regularly, say you say once in 6 months, you can come and show. But if he gets 1, 2, 3, if he gets joint pain, if he gets fever beyond 3 days, if he gets breathless, or he has dyspnea on exertion, or he gets chest pain, then you must come before turn, right? And prognosis you have already explained, long-term management you have explained. So I think that's a job well done.
We're done.
I'm done.
So with this we come to the conclusion of today's broadcast. Thank you so much for staying with us. The next broadcast should be from Chennai if things normalize there on the 9th of December 2:30 p.m. onwards from Kanchi Kamakoti Child's Trust Hospital. If there is a change in the program, you will get a message from IAP. Thank you again.
That's a totally different counseling.